Okay, good afternoon everybody. My name is Naomi, and on behalf of Turning Point I'd like to welcome you to this live streamed Talking Point presentation. I hope you're all well, and I apologise for keeping you out of the beautiful Melbourne spring sunshine for about an hour. I would like to begin by acknowledging the traditional custodians of the land on which we work and live, and recognise their continuing connection to land, water and community. We pay our respects to elders past, present and emerging. Our speaker today is my much valued colleague, Victoria Manning. Victoria is an Associate Professor in Addiction Studies at Monash University and Head of Research and Workforce Development at Turning Point. She holds a PhD in neurocognition and co-occurring disorders. She is a research psychologist with over 20 years' experience working in AOD treatment services in the UK, Singapore and Melbourne. Victoria's passion lies in trialling neurocognitive, psychological, pharmacological and other novel interventions to optimise treatment effectiveness for people with substance use disorders, and examining the role of peer support models in promoting recovery. She teaches on the graduate program in addictive behaviours course at Monash University and is currently a board member of the Victorian Drug and Alcohol Association, VADA, and a member of the SMART International Research Advisory Committee. The title of Vic's presentation is Pushing Away Your Poison, Using Cognitive Training to Improve Client Outcomes in Addiction Treatment. Thank you, Vic.
Thanks, Naomi. Good afternoon, everyone. So, yeah, my title is Pushing Away Your Poison, and I promise you that will become a bit clearer once we get into it, but I will be providing a bit of an overview of different types of cognitive training, but focusing most importantly, from my opinion, most importantly, on cognitive bias modification and approach bias modification specifically, because that's a program of work that we've been doing here. So, the paradox of addiction is that we have continued use of substances despite knowing or experiencing its harms, and often despite a strong desire to cut down or quit. And the dual process model attempts to explain this paradox by viewing the behaviour as a consequence of an imbalance between two independent but interconnected information processing systems. So the first is the motivational or limbic system with its fast automatic information processing that drives impulsive behaviour, and this becomes overactive. And the second is the slow reflective or regulatory system of the frontal lobe, which allows us to monitor and regulate behaviour and keep those longer term goals in mind, which becomes underactive. So with repeated administration of substances sensitising the reward system, it sort of ramps up the implicit impulsive processes, and at the same time it's weakening the executive control system, making it harder to apply the brakes over those impulsive behaviours. And while psychological therapies generally aim to strengthen top-down reflective processes, they fail to address and therefore leave intact these implicit subconscious impulsive processes, and that's where we think cognitive bias modification can play a key role. So research tells us that some of the consequences of altered or impaired cognition is that we tend to see more severe or longer term substance use, poorer treatment engagement and poorer treatment adherence. We see high rates of dropout and of course often poorer outcomes. And the studies tell us that anywhere between sort of 50 and 80% of people with substance use disorders experience cognitive deficits, particularly in those higher order cognitions, executive functioning, such as working memory, cognitive flexibility, inhibition and decision making, and that there's a tendency to select smaller, more immediate rewards over larger ones that will come later in time, and that's known as delayed discounting. And many of these executive functioning deficits have been shown to predict relapse. But most of the psychological approaches that we use, such as cognitive behaviour therapy and motivational interviewing, these rely quite heavily on some of the higher order executive functions. We're sort of relying on the ability to attend to information and recall it, keep track of things, plan, weigh up options, consider things from multiple perspectives. And therefore, if we can strengthen these cognitive processes directly using cognitive training, then we should be able to help people better engage in them and get more out of psychological interventions. broadly speaking, there's sort of 4 branches of cognitive training that have been tried and tested. There's cognitive remediation or cognitive rehabilitation training, which targets multiple cognitive functions, typically attention, memory, executive functioning, and self-regulation. And it often combines clinician-guided sort of group therapy approaches with computerized training, and it will maybe be somewhere between 2 or 3 sessions a week over multiple weeks during a treatment episode. And a particularly promising approach within that category is goal management training, which focuses on increasing awareness and response inhibition, goal setting and attainment, and decision making, with training, practice and strategy learning to really strengthen the transfer of these skills to goal-related tasks in everyday life. Working memory training aims to improve the ability to hold, integrate, manipulate or prioritise information to support healthier decision making, and it typically requires participants to repeatedly manipulate and recall sequences either of shapes, numbers, letters, that sort of thing, in computerised tasks, and these become increasingly difficult over time, stretching working memory capacity. Inhibitory control training aims to improve impulse or reduce impulsivity, improve impulse control by repeatedly inhibiting a motor response to a reward-related stimuli. So it could be an image of a beer bottle, for example. And usually you withhold from pressing a button when you see that image, and you make a response when you see a neutral, non-alcohol or drug image. And you do this over multiple trials, and usually in the form of a task either called the go, no-go or the stop signal training task. So the next few studies I've just skipped CBM actually. Shouldn't leave that one off. So CBM is really, as I said, I'm going to focus on this very much today, but it aims to dampen cognitive biases and interrupt the autopilot response to cues that drive impulsive behaviour. So the next few tables that I'm going to show you, the next few slides, really sort of summarise the literature on these different types of cognitive training. And so you've obviously got the authors and the dates of the studies on the far left. Next to that is a population that was studied, and it's generally clinical or treatment-seeking populations, unless they just didn't have any studies on that population. The substance that was targeted, the type of training program that was used, and then the first coloured column on the right-hand side is whether that cognition or that either cognitive function or the cognitive process was successfully targeted. So that could be either increased or decreased, depending on what it is. And then the column on the far right, the coloured column, is whether or not substance use reduced as a result of that training intervention. And so, as you might expect with something like cognitive remediation or cognitive rehabilitation, which is targeting lots of different aspects of cognitive functioning, we do see an improvement on at least 1 or 2 domains in the sort of global assessment batteries that are used to assess their effects. But to date, only 2 studies have shown reductions in substance use. Moving on to working memory training, about half the studies here have shown improved working memory, at least on similar measures of working memory to that used in the training task, which we call near transfer effects. Unfortunately, there's only sort of a small amount of evidence suggesting that we get far transfer effects, which is when we see working memory performance improved on tests that are not that similar to the training task or on other executive functioning tasks, which would suggest we are building working memory capacity, increasing mental flexibility, which could support better decision making. I guess the greatest limitation in the working memory literature is the failure to examine or at least report actual substance use outcomes. And to date, we've only seen that in one study where there was a reduction in alcohol use, but unfortunately it was in a non-treatment seeking population. And we really need to do more in this area because, given the intensity of working memory training and the kind of theoretical rationale for why you'd want to do it, it's quite intensive. So we really need to invest more in this area as well. Inhibitory control training is an interesting one because mostly it's only been a single session of training as opposed to the previous types of cognitive training, which tend to be multiple sessions. It's not really quite clear whether it does indeed reduce impulsivity based on the measures used in those studies, but most of them have indeed shown a reduction, at least in alcohol use, although again, it's limited to a non-treatment seeking sample. One exception to that, at the bottom of the table there, is a recent study of people undergoing treatment for cocaine use disorder, whilst impulsivity scores reduced or improved. Cocaine use, however, was unchanged. And again, we need more studies of inhibitory control training with people who are seeking treatment for substance use disorders. And then moving on to cognitive bias modifications, which I'm sure many of you are familiar with this by now. It's been touted by some as a bit of a sort of fifth wave of psychotherapy. We had publications at the beginning of the century. And there are two main types that have been applied to addiction treatment populations, which is attentional bias modification and approach bias modification. Attentional bias is a tendency for our attention to be selectively captured or automatically captured by something that has value or meaning to us. So it could explain why somebody who's trying to get pregnant, for example, suddenly feels like they're surrounded by pregnant women. Or when you buy a new car, you suddenly start seeing it everywhere on the road. And in the case of alcohol, it's a tendency for our attention to be automatically captured by cues in the environment that represent alcohol. And it could be an advertisement, a pub, a restaurant, a bottle, anything really that over time has become associated with the pleasurable effects of drinking. You may notice that your gaze automatically shifts to a beer or a wine bottle in the fridge at a certain time on a Friday evening when you're going there for the milk. These learned associations between alcohol and related stimuli can have a really strong influence on our behaviours at a subconscious level, or at least a semi-subconscious level. And that's what makes it really difficult to control. Somebody told me recently that they would enjoy, at the end of the day, having a few gin and tonics on a certain chair on their veranda. They were trying to stop drinking, and every time they saw that chair throughout the day, it was a reminder. They suddenly got an intense craving or urge to drink. So in the end, she moved the chair, and I'm pleased to say has managed to avoid some drinking days. But the good news is the strength of biases to cues and their associated feelings or responses can be interrupted and at least somewhat reversed with attentional bias modification. And it's important to say that it was originally developed by Colin MacLeod and his team to treat anxiety disorders, where computerised training would train people with anxiety disorders to divert their attention away from threatening cues and towards non-threatening cues, and therefore bring down anxiety levels. And it was really a group of researchers in the Netherlands and Germany who were the first to take this and apply it to people seeking treatment for substance use disorders, specifically alcohol. So in attention bias modification, it's essentially a variation of the dot probe task. You see a fixation cross initially for about a second, and that's replaced by a screen with an alcoholic beverage one side and a soft drink on the other for about half a second. That's then replaced with a screen with two dots. So the two dots will either be where the alcohol was or the soft drink was. And you have to indicate the location of those dots as quickly as possible using keys on the keyboard. But because the dots almost always replace the soft drink, you learn to divert your attention away from the alcoholic drink and towards the soft drink, because that's where the dots are likely to appear, and therefore if you're already looking there, you'll be quicker to respond. And in the attentional bias modification literature, it has been shown to reduce attentional bias, and in about half the studies, and quite a few studies have shown a reduction in substance use, mostly alcohol, but it's important to note that quite a few have not seen a reduction in substance use as well. And whilst attentional bias is a tendency to notice cues or sort of have your attention drawn to cues, approach bias is the tendency to move towards or approach rather than avoid alcohol or drug cues, which then drives us to seek out substances and consume them. And I'm just going to, hopefully, if this works, share a 1-minute animation that we had made up to explain approach bias modification to people who will be using it as part of their treatment.
Psychological research suggests that we are hardwired to push away or avoid things that we don't like, and to approach things that we do like, be that a cute puppy, chocolate cake, drugs, or alcohol. In people who drink frequently, alcohol cues such as places, sights, and sounds that remind us of drinking can subconsciously capture our attention. This can drive impulses to seek alcohol, and scientists call this tendency a cognitive bias. This automatic response to alcohol cues makes it difficult to resist drinking, even when we have other things planned. Thankfully, researchers have developed an app called Swipe, which uses a form of brain training called cognitive bias modification. Swipe aims to interrupt the autopilot response to alcohol cues by training people to repeatedly push away images of alcohol and to approach healthier alternatives. Research has shown that just a few sessions can help people to reduce their drinking. Simply choose the drinks you want to stop drinking and the activities you want to start doing more, and you're ready to override your alcohol autopilot.
Good. I believe that worked. So, as the sort of animation suggests, a lot of this is happening at a semi-subconscious level, and it can feel sometimes like a bit of an external driving force. And I really love the latest campaign by the Alcohol and Drug Foundation, Don't Let a Small Habit Turn into a Big Problem, where they have that little purple gremlin by the wine bottle. I think that's really clever, because sometimes we can apply all the logic and all the self-talk, all the conscious cognitive thoughts in the world, telling ourselves, you know, tonight is my goal to not drink. I want to get up early. I want to go for a run. I want a sharp brain in the morning. I don't want the calories. I know it's bad for my health. I can't afford it. We can have all these reasons, but yet still something sometimes kind of feels like it takes over and takes us there. And we think of that as the alcohol autopilot response to those cues. And it can explain why sometimes we might find ourselves reaching for the fridge to grab a beer before we've even consciously decided we were going to have an alcoholic drink. But as I said earlier, the fact that it's so automatic and sort of semi-subconscious, it makes it that much more difficult to control. And so we need to reverse this by subconsciously training the brain to automatically avoid rather than approach alcohol-related cues. And so we're thinking that by dampening our alcohol autopilot, we can buy ourselves time to put into practice the strategies that help us make better decisions. So as we saw in the animation, people are sort of pushing or pulling on a joystick, but they're not explicitly made aware of the training contingency. So they're not told to push alcohol and to pull soft drinks, but they're told to respond to an irrelevant feature, which in our case is the orientation of the picture frame. So they're instructed to push the joystick forward when it's in the portrait orientation, which shrinks the size of the image as if they're moving away from it, simulating an avoidance movement. And they're told to pull on the joystick when the picture is in the landscape orientation, which zooms in on it, bringing it closer, simulating an approach movement. And in this way, people are attending to and responding to the image frame, but they're sort of being implicitly or semi-subconsciously trained to avoid or reject alcohol cues. It is a fairly monotonous, repetitive task, as you can imagine, but by repeatedly practicing this automatic avoiding alcohol, it makes it easier to sort of practice and less effortful. So in the literature on approach bias modification, there is evidence of a reduction in alcohol approach bias. So if somebody's quicker to pull on the joystick or approach alcohol than they are to push the joystick and avoid alcohol relative to how they respond to those to soft drink images with those responses, then they're considered to have an alcohol approach bias. And with the exception of one study where alcohol approach bias was not assessed, which was actually our pilot study, all of the ABM studies have shown a successful reduction in the targeted mechanism, so approach bias, and all but one of them has shown a reduction in actual alcohol use after training relative to controls. And there's some promise of its application to other drugs. There's a fairly recent study looking at people with cannabis use disorder, which seemed to work in the male participants. And I'll be sharing with you in just a few minutes some findings from a study where we applied it during methamphetamine withdrawal. And although these findings look promising, they of course need to be replicated and they need to be examined in much larger populations using more robust methodologies with active placebo-controlled designs. So these three studies that you see here are the sort of largest, most robust, well-powered studies that all took place in Germany, and where now CBM or approach bias modification specifically is actually part of the treatment program. It's sort of treatment as usual in many of the treatment services there. So they were able to show this reduction from a mean approach bias before training to a mean avoidance bias after training, or in some studies, a sort of strengthening of that pre-existing avoidance bias. And it's important to note that these studies were conducted on participants who were about 6 weeks into their treatment episode. So they'd gone through inpatient withdrawal and they were in a resi rehab phase of their treatment. But importantly, these three studies have shown that this training, 4 to 6 sessions of this ABM training, can actually reduce relapse of somewhere between 8 and 13% 12 months later, so 12 months after they've undergone the training. There's a couple of fMRI studies conducted by that group I've just shared with you in Germany. And the findings from those studies suggest that at least we think it works by reducing the motivational salience or the value of alcohol cues, because people with alcohol dependence show reduced neural activation when viewing alcohol cues in the amygdala, which we know is involved in craving, and in the medial prefrontal cortex, which is implicated in assigning the value of a rewarding stimuli and initiating drug-seeking behaviour. And this was the case after doing 6 sessions of ABM relative to a sham training control condition. And also the reduction in activation correlated with the subjective craving scores. So we were interested in whether we can apply this during alcohol withdrawal. And that's because we know, literature suggests around 85% of clients will relapse within 12 months after an alcohol inpatient withdrawal treatment. And we know that more than half of our clients tend to do so in the first few days of being discharged. Preventing early relapse is important because we know that people are less likely to engage in outpatient counselling and aftercare once the drinking has resumed. And so clients typically leave a very highly protected, structured environment and return to a community where they're bombarded with visual, auditory and olfactory alcohol cues that can then trigger craving. So in a pilot RCT, a pilot double-blind RCT, we had 83 participants who were undergoing a 1-week withdrawal program in a single site, randomised to receive either 4 sessions of ABM, where they were pushing away pictures, they had 240 trials, pushing away images of local brands of alcoholic beverages and pulling towards them or approaching non-alcoholic drinks. Or they were randomised to a sham training control condition where they responded on the joystick according to the picture orientation, but there were 2 sets of neutral stimuli. And what we found were 4 sessions reduced relapse by 30%. So 75% of the ABM group told us they hadn't had a single drop of alcohol after leaving the inpatient withdrawal unit at that 2-week follow-up, compared to only 45% of the control group. And this difference was 22% when we took a more conservative intention to treat approach, and that wasn't significant. But it was significant when we looked at the per protocol 4 sessions. So we then went to see if we can use it with people who are going through methamphetamine withdrawal, because we know that's the second most common reason for seeking treatment and for inpatient withdrawal. But up until that point, it had only really been used with people wanting to quit alcohol or cigarettes and not illicit drugs. And we did have some concerns that the images would be too triggering or cause some psychological distress, that perhaps it wouldn't be as well tolerated, because we do see these fluctuations in sleep, mood and motivation during methamphetamine withdrawal. So before running a trial, we really wanted to see whether it was appropriate to do this. So we explored the feasibility and acceptability and observed the outcomes in a sample of 47 clients from 3 different withdrawal units. They got 4 consecutive days of training where they were trained to avoid or push away images of methamphetamine, could be injecting or smoking or other meth-related paraphernalia, and they were trained to approach images of fruit and veg. And we were pleasantly surprised by the findings. In terms of feasibility, it was more challenging than we typically see when applying this to people undergoing alcohol withdrawal, but we still managed to get about 62% completing all 4 sessions. And the really good news was that only 4 people withdrew, and they said they were just too triggered or distressed by the methamphetamine images. The acceptability was high. 80% said that they'd found the task, or agreed or strongly agreed with the statement that the task or training was interesting. A similar 75% agreed that it improved their attention, although only a third felt that it actually helped reduce their craving. Having said that, we did see a significant reduction in their craving score on a standardised measure, but of course that could just be a feature of or a consequence of the detox itself rather than anything to do with the training. But in terms of the outcomes, 2/3 reported total abstinence from methamphetamine at that 2-week follow-up, and over half did at 3 months. We did lose a lot of people to follow up, but even if we assume that those that we weren't able to successfully recontact, the abstinence rate of around 30% is still substantially higher than that's been reported from Australia's largest methamphetamine treatment outcome study, which was the MATE study. So overall, we were pretty pleased with what we observed with this study. And then we were fortunate to secure some funding from NH&MRC to do a double-blind, multi-site RCT of approach bias modification during alcohol withdrawal. So this time we had 300 participants that came from 4 different inpatient withdrawal units in Melbourne. And it was double-blind in that the researchers who did the follow-up calls were not the same researcher who'd either recruited them to the study or overseen their training. Again, we wanted to replicate the pilot as much as possible, so we did the 4 consecutive days of training, typically starting on day 3. So they would do some baseline measures of alcohol dependence, craving, approach bias, and then the laptop would essentially randomise them to one of these 2 conditions, the active ABM group or sham training controls. In the active group, there were 240 trials and they were pushing away alcohol 95% of the time. In the sham training group, they were instructed to make lateral movements on the joystick. So instead of pushing forward and backwards in response to the picture orientation, they moved the joystick left for landscape and right for portrait. So there was no change in the image size and therefore no approach avoidance training in the control group. We kept at the 2-week follow-up as the primary outcome because we wanted to replicate that finding from our pilot, but we were also interested in whether any benefits in terms of prevention of relapse are maintained over time at the 3, 6 and 12-month follow-up, which we're still in the process of looking at. And then, we adopted the same conservative intention to treat approach, looking at the outcomes of those who may have only done the 1 session, and also looking at the per protocol, those who did all 4 sessions as intended. We have a whole series of secondary outcomes. Today I've only really got time to talk to you about the change in approach bias. So many of them we haven't even looked at, and the analyses are being performed by an independent statistician. So in terms of the characteristics, I think it's pretty typical of what we see in terms of gender, age, etc. for inpatient withdrawal. In terms of the clinical characteristics, they were quite severe. They had moderate to severe alcohol use disorders. They had a mean of 10 out of the 11 criteria on the SCID. There was evidence of very high consumption, almost daily drinking, high rates of comorbidities, high rates of smoking and previous treatment episodes. But importantly, there were no significant differences between those who were randomised to the active ABM group and those who were randomised to the control group. So in terms of the results, as I mentioned earlier, we took an intention to treat approach, looking at those who may have only done the 1 session, and we found even with that, we had a significant difference, a 12% difference in favour of ABM. So 54% of the ABM group reported no alcohol use at the 2-week follow-up compared to 42% of the control group. And that's assuming anyone that we had lost to follow-up had resumed drinking. And when we look at the per protocol approach, then that increased to 17%. So nearly 64% of the ABM group had not consumed any alcohol in that 2-week period post-discharge compared to 47% of the control group. So we were really pleased to have replicated our findings of the pilot study of this sort of helping to reduce relapse when added to inpatient withdrawal treatment. So just to share with you the changes in approach bias that we observed, the ABM group is represented by the blue line, the sham training control group by the purple line. So looking firstly at the figure on the left, which is alcohol approach bias, we observed a post-training significant group by time interaction, which was due to the significant reduction in approach bias in the ABM group from a mean approach bias at baseline to a mean avoidance bias after training, whereas in the control group it remained very much an approach bias. But what surprised us was that we actually observed I can't say significant because it's 0.055, so it's teetering on the edge of significance increase in approach bias to non-alcohol cues in the ABM group, and no change really in the control group in non-alcohol approach bias. So that was unexpected and not necessarily desirable because of course it's better to have an approach bias for non-alcoholic drinks than alcoholic drinks if you're wanting to stop drinking. But we did include some very healthier beverages in the range of non-alcoholic drinks, but many of them were sodas and juices with high sugar content. But the reality is it would be a very, very boring task if people were only ever approaching glasses of water. We also asked participants to rate their craving immediately before and after each training session, and the main motivation behind this was to make sure that it wasn't, distressing for them. If anybody did show an increase in their craving score after doing a training session, we would either do a sober breathing, a mindfulness-based breathing exercise with them, or we'd get a clinician in to sit and practice some strategies for managing alcohol craving so that they would be in a good place when they leave the ward. But what we observed were, fortunately, only 7 actually did withdraw due to being triggered by the alcohol images, and that was 4 in the ABM group and 3 in the control group. But what we found when we analysed the craving scores was a significant effective session where craving decreased for both groups over the 4 sessions, as you can see here. The green bars are the ABM group, the sort of solid bar is post-training, and the purple bar is the control group. Again, solid bar is post-training. And we found a significant interaction between group and time being pre or post-training, whereby the craving score decreased after training in the ABM group, as you can see here, and it increased in the control group. So this was good news because it suggests that it's safe in that the ABM training itself doesn't actually increase craving. Exposing them to all those images of alcohol certainly didn't increase acute craving. We also asked participants the same questions that we've used in our prior studies, how they found the tasks. We had 3 statements and generally indicated high acceptability. 80% agreed that it's interesting, and a similar proportion agreed that it improved their attention. And again, only around a third reported that they felt it decreased their craving. But the important thing here is that there were no group differences, which suggests that both types of training were, I guess, acceptable, but it wasn't necessarily obvious who was in the control group and who was in the active training group. And I just want to share this quote with you, which we were delighted to hear when one of the researchers did a follow-up with one of the participants, because it seems to have a lasting effect. She told us, I went to my usual bottle shop. I went to buy my usual bottle of vodka from the bottle shop, but when I saw it there on the shelf, all I could think about was pushing it away from me. I left the shop having not made a purchase. So we were really pleased to hear that it sort of carries forward. In conclusion, the findings really do add to the existing and very much growing body of evidence that approach bias modification is an effective add-on to alcohol treatment, though its promise with other drugs needs to be further tested with more rigorous designs and methodologies. And there's further evidence that we can strengthen avoidance bias, but there's also new evidence from our trial that we can increase approach bias to non-alcohol images, which could potentially be leveraged to have a therapeutic effect in itself. There's evidence that the training is highly feasible, especially relative to some other forms of cognitive training. It's very easy to implement. It's brief, it takes around 10 to 15 minutes. It's based on theory, it's cost effective, and it requires minimal equipment, just a laptop and a joystick, though they are fast becoming obsolete and quite difficult to get hold of these days. So we really do need to think about different modalities for delivering ABM. And there's minimal training requirements as well. I think the instructions are pretty simple and it can be easy for clinicians to administer. The limitations of the study were that we were reliant on self-reported alcohol use at that telephone interview, 2 week follow-up. Because some of the services were inpatient withdrawal units were statewide services, it wasn't possible to get everybody back to do a breathalyzer or for other alcohol biomarkers. And the other limitation is obviously today I've only presented the early relapse prevention effects at 2 weeks. We haven't even looked at the data at 3, 6 and 12 months, and some of that's ongoing in terms of data collection. But on the basis of what we found and what we know from the studies in Europe, we would recommend it as an adjunctive treatment approach to optimise client outcomes, at least in terms of preventing early relapse in residential settings. Future directions, I think going back to what I was talking about at the beginning in terms of other types of cognitive interventions, there's potentially a role for synergistic approaches. We may benefit from, say, starting with CBM to dampen those subconscious processes because it's very straightforward during detox, and then maybe progress to sort of strengthening top-down executive control process with training such as working memory training or goal management training later on in the treatment episode. And as I mentioned earlier, we need to establish its efficacy with other types of substances, particularly opioids, cannabis, methamphetamine, etc. And also, I guess, to a degree, most of the research has been conducted in inpatient settings or residential settings, so we need to see how it works outside of those. But some key research questions for our research group are whether we can improve approach bias modification by personalising the avoid stimuli, and whether we can improve it by personalising the approach stimuli. And also whether we can deliver approach bias modification over a smartphone, because that would then enable us to offer booster sessions once clients leave treatment, but also opens up that opportunity to extend it to people with alcohol problems who don't wish to seek treatment. And that's exactly what that's exactly what we're doing. To illustrate why we think personalising is so important, or possibly the way forward, we asked participants in our alcohol trial how much they wanted 10 different alcoholic beverages, and you can see the scale there from I don't want this drink at all to I would really love to drink this. 5 of the drinks had been in the training task, so there'd been drinks which they were trained to avoid, and 5 were completely novel, as in they were not in the training task. And we did this so we could see whether the training indeed generalises to untrained stimuli. But just to sort of share with you the personalisation idea, this rather messy looking figure here shows the scores, the wanting scores for maybe the first 4 or 5 participants. And you can see that the participant represented by the orange line here, this person really wanted all of the drinks except for whatever drink number 3 and drink number 9 were. In contrast, the participant represented by this solid blue line here, they didn't really want any of the drinks apart from drink number 7, whatever that was, and others are sort of somewhere in between, up and down. So it does seem to be important to consider the image, or at least maybe the brand or the drink type that's displayed. And so for someone who only drinks red wine, for example, undergoing training to automatically avoid beer or spirits may have little impact, as they're in a sense already avoiding those. I do recall one woman that I did some training with, and she told me she only really drank champagne, and she was quite repulsed when she saw some of these other alcoholic beverages, and indeed the soft drinks as well. And we tend to see a more limited range of beverages, at least among those who are seeking treatment or inpatient withdrawal treatment. So our thinking is that we can possibly increase the effectiveness of ABM if we train them to automatically avoid the images of drinks that they're most struggling with and most want to stop drinking. So it gives me great pleasure to introduce Swipe. I'm very excited to have finally launched the team finally launched this, the world's first personalised ABM training programme delivered via a smartphone app. So this is really enabling us to take the training that we've been doing in treatment services to the community. So Swipe works by training people to swipe away, or using a swipe up motion on their phone, pictures of the exact drinks or brands that they want to stop drinking, and they can either select those from the app itself, take a screenshot from the web, or take photos using their cameras on their phone, and hence they're pushing away whatever is their poison. But rather than swiping closer soft drinks, participants swipe towards them images that have personal meaning to them. So we encourage them to put into the training task photos of their family, friends, pets, hobbies, travel, images that represent health and well-being, or alternative activities to drinking that perhaps they'd like to start doing more. Really anything that relates to their goals or their values, so we can simultaneously strengthen intrinsic motivation for behaviour change, just as we would with psychological therapies. So we're sort of thinking of it as a bit of a dual target approach, both dampening alcohol approach bias and reinforcing positive motivations. And another great thing about having it delivered via an app is that we can make it more sort of game-like by recording the score for speed and accuracy, which people aim to beat with each training session. And our hope is that it will by making it more personally relevant, it will make it more engaging, and therefore will help people reduce their alcohol craving and consumption. And down the line, we're hoping it could offer a free, discreet, anonymous, just-in-time intervention that could help curb craving at peak times, regardless of time or location. So the trial that we've just launched is aiming to recruit anybody who wishes to reduce their drinking, who falls into the harmful or hazardous category on the audit. And after downloading the app and selecting their 6 positive and 6 alcohol images, they're required to do 2 7 to 10 minute training sessions a week. The app sends notifications for those training sessions, and at the end of the week they're asked to record the number of days in which they consumed alcohol and the number of standard drinks per drinking day. And then we check in with them a month later to see how they're going. So if you know anybody who would be interested in trialling Swipe, it's an open label study, but please do tell them to visit swipe-app.com.au. We are hoping to test its sort of acceptability, feasibility, user experience, all of that, as well as reductions in drinking and craving with 500 people over the next sort of 6 months. But I'm delighted to say that we've almost reached our target in the first 2.5 weeks. And it's really great to see that we've got people coming from all over Australia, including some remote locations. And just to, this is my last slide, but just to sort of say we're not just purely focused on alcohol. Just before COVID hit, we'd commenced a trial looking at delivering customised ABM for clients undergoing a 1-month resi rehab program for methamphetamine use disorder. And we were looking to do this across 3 different treatment services. And we're very delighted, we're very grateful to have worked with APSU and consumers who helped us select the types of meth images and positive goal-related images that clients will self-select to be used in the training tasks. And so our hope is that, again, by personalising it to a degree, that we'll get better engagement and possibly better effectiveness compared to a sham training control condition where they're pushing images of meth, standard images of methamphetamine and standard images of positive goal-related behaviours 50% of the time. So I'm hoping we'll soon be able to get back to completing that study, which was funded by the National Centre for Clinical Research on Emerging Drugs. I'd just like to acknowledge the incredible, diverse, amazing group of people that I've had the pleasure of working with. My co-investigators, the researchers and students, the staff and clients at all the treatment services, international collaborators, volunteer researchers, and of course my funders, or our funders. And I would like to thank you for listening and encourage you, if you have any questions or thoughts, please get in touch. I've left my email address up there. If you're thinking that you might want to try it with clients in your practice, ABM or Swipe, please let us know. We're really keen to take it to the next level. We feel like we've demonstrated it works with clinicians doing it, but with researchers doing it, but we'd really love to see clinicians adopting it in practice as well. And yeah, I mean, for some treatment services where clients have access to their phones, Swipe may be an option, with the caveat, of course, that whilst it's an evidence-based intervention, we haven't yet proven its effectiveness when delivered via the smartphone app. And we also have many opportunities for PhD students. If any of you are interested in this area or know people that are, we have so many ideas about populations and the ways in which we could adapt Swipe, and some key research questions that we think still need to be answered. So we're always keen to discuss research collaborations, ideas. I could talk about this all day, as I'm sure it's pretty obvious. Anyway, thank you for listening, and I'm going to let Naomi tell me what questions have come through.
That's all right. We're going to be COVID safe here and come in and out of screen and make sure we keep our distance during this question and answer period. That was brilliant. I love hearing about new and innovative treatment techniques, because sometimes it seems to me, particularly when you've been around for quite a while, that we're doing the same old thing all the time. And so while we know that there are some techniques, some true and tried classical treatment techniques that work, it's always great to have new tools in the toolbox, so to speak, and I think this is a great new tool. I love Vic's enthusiasm and when she's talking about it, and she's so great at talking about it that she actually answers all the questions that were posed as she's talking. So there were questions about the personalisation of the images, and I think Vic has answered those, and also questions about how clinicians and clients can access this particular treatment, which I think Vic has answered as well. I've just got a question, Vic. I'm interested because when I first studied counselling and psychological approaches to treatment, it was very much emphasised to me that an important part of any treatment approach is explaining the rationale to the clients and having them sort of on board with the rationale, which maybe to some extent provides a bit of a placebo effect. But I think it is, you know, there is some importance in people understanding why they're doing certain things. And yet in this treatment technique, you're sitting people in front of the screen and not really telling them what they're going to be doing. And I'm just wondering if you'd like to explain why you take that approach and if you think there's any advantages or disadvantages to clients perhaps understanding why they're doing the training.
Yeah, that's a good question. So it was interesting recently, the idea, I mean, Katrina Pryor, who's doing some similar work in approach bias at UNSW, was sharing some findings from a study where she looked at, the sort of feasibility and asked people what would make you want to do this more, and they said, well, having a sort of stronger rationale of why I'm doing it, because it does seem quite random, you know, pushing and pulling on a joystick. And so, you know, we're pleased that we put together that animation. Of course, we'd never use that in a research study where we have a control condition because there would be an expectancy bias. But I think, yeah, the idea about sort of not saying you're pushing alcohol, you're avoiding alcohol and you're pulling soft drinks, it's really more so that they attend to the frame orientation. So that's where their attention is going, and sort of at a more subconscious level, they're being trained to push away or avoid alcohol. Yeah, and of course it makes the task more engaging as well. There has been a study, I think again it was by Reinhard Weirs and his group, where they compared explicit instructions, so when they said push alcohol, pull soft drinks, versus implicit instructions, so push portrait, pull landscape. And there was very little difference actually, whether it's implicit or explicit, but I think it definitely makes the task more engaging. But I think also, you know, explaining to participants why they're doing it and that it is something new, it is sort of targeting the more sort of reptilian brain, if you like to use that terminology. You know, there's kind of more sort of subconscious kind of automatic processes where a lot of the mainstream psychological approaches we use are typically top down and strengthening cognitive control. Then it's, in that sense, it is a useful adjunctive, yeah, as an add-on.
Thanks, Vic. And we've had a question about reduction versus abstinence. So is the purpose one or the other, or what do you think should be the goal of treatment?
Yeah, I didn't have a chance to present all the secondary outcomes, but yeah, we didn't see, in those who did resume alcohol use post-discharge, we didn't see a reduction in the amount that they were drinking or in the number of days that they were drinking. So it does seem to be working in terms of preventing that lapse, or, you know, preventing resumption, if you like, or the actually engaging in alcohol use or drinking again after the treatment. It doesn't seem to, at least in our treatment studies, we haven't seen evidence that it can help people cut down. It's really more of a sort of, yeah, prevention. But having said that, the only other study of a smartphone version, which again was conducted by a group in Germany, so they gave participants, I think it was 3 weeks of twice weekly sessions. It was a standard set of alcohol images and a standard set of soft drinks that they were trained to swipe on their phone. So approach and avoid. And they actually saw a reduction of about 8 standard drinks over the course of treatment. So, I mean, it's a different population. It's not necessarily, you're not necessarily got alcohol dependence in that population. So maybe it works better as a way of preventing relapse in people seeking treatment who are highly motivated to stop drinking generally. And it can be an aid in terms of harm reduction, reducing alcohol consumption in people who are not seeking treatment. We shall hopefully have some answers to those questions soon.
Thanks, Vic. And we've had a couple of questions about different poisons, I guess.
Yeah.
So what's the applicability of this particular approach for example, helping people with compulsive eating problems? And we've also been asked about smoking abstinence or reduction.
Yeah, I apologise. I didn't present the smoking literature, but it's pretty promising actually for attentional bias and approach bias modification. And the question about eating always comes up. Can you use this? That's almost always the first question. Will it work for chocolate? And the good news is, yes, it looks like it can. I was at a symposium just last weekend, and Professor Eva Kemps from Flinders University is actually trialling approach bias modification as a way of reducing chocolate consumption. So her studies have shown that you can indeed reduce an approach bias to chocolate. And they did this, it was with, I think, about 120 young women, but they actually did a taste test after the training as well, where they said to the participants, you can have as many or as much of this chocolate muffin versus this non-chocolate, I think, blueberry muffin. And then they weighed how much was eaten, and indeed there was less consumption of the chocolate muffin. So it's looking promising. And Naomi Kokoschke, who was also at Monash, she started trialling this in terms of sort of reducing approach bias to unhealthy foods, you know, with high fat and high sugar content. So it's a new area, but there seems to be a lot of potential application. So yeah, it's very exciting.
Yes, I'd be a little bit concerned about access to that treatment for people with anorexia, that, you know, they might use it as a technique. There was a question that we've had about feasibility, and you've looked at how clients respond to this particular treatment and their acceptability of it, and just wondering if there's been any research around clinicians' acceptance and views about the treatment.
Not really, not that I'm aware of, but it is something we have not just thought of. We actually have a grant submission to really look at this, because we really want to, you know, the implementation of it. You know, we're not doing this just for fun. We actually we'd love to see it introduced into practice. But interestingly, again, the German and Dutch group of researchers who've really pioneered a lot of this work, they looked to see whether in one of their big trials, where it seemed to, I mean, I think they had something like 20 different treatment services involved in the trial, and maybe 1,300 participants that went through this particular study, but they were trying to work out, why does it work in some services and not others? And so they did some kind of assessment of clinicians' attitudes, I guess, and belief that it would work, to see whether that had an effect. But no, they said it had absolutely zero. So services that were very supportive and into the idea of doing it had similar outcomes, or at least didn't have better outcomes than those where clinicians were less positive about it. So it's definitely an area we want to get a good understanding of. Yeah, good question.
So we've already got some people who are interested in improving your app, Vic, or have some ideas for improving the app, which I think is really great.
Oh, good.
So somebody suggested, has anybody thought about providing rewards like lights or bells or some sort of reward for picking the correct options?
Yeah.
Yeah.
Yeah, we do. I mean, I can't really bring myself to say gamified in today's context, but we do have, as people are doing the training, they get points for how quickly and how accurately they respond. I think, you know, sort of 3 gold stars if they respond in a few milliseconds and make the correct movement, approach or avoid. But yeah, that's a really good idea. It's also not knowing how you strike that balance between it not being irritating, because, you know, with the sound of ding ding, or, you know, that could be really annoying. And we also it was really important for us to keep it discreet as well, so somebody could sit and be doing it without anybody necessarily knowing what they're doing. But yeah, there's lots. This is really very much Mark 1 or version 1 of the app, and already we've got ideas about what we think would improve it, and we're only 2.5 weeks into the trial. So yeah, would love to hear more if you have other ideas. But yeah, hopefully one day when we know, or if we can demonstrate that it's effective, we'll have what we're calling the bells and whistles version.
Thanks, Vic. And one more question about whether there have been studies that have looked at people who have not previously been to rehab.
Yes, they have. In fact, it started out, the research very much started out looking at student populations, and The big difference, and there's been a couple of meta-analyses, or one particular systematic review meta-analysis, which really demonstrated the importance of making that distinction between people who are very motivated to reduce their alcohol use, i.e. people seeking treatment, versus those who, who are drinking and not really that motivated to change their consumption. And yes, so we do see better, or it's more effective when it's added to treatment, and that's really the thinking behind it, that it's about motivation. So whilst it has been, the early sort of single session did show reductions in alcohol consumption in student populations, when they've tried to do it online and when they've tried to do it in non-treatment seeking populations, there's generally not been as effective. It's very much a tool to improve treatment outcomes.
Thank you. And one last question, which I think you've probably answered, but maybe it's worth just reiterating a bit more. Because somebody asked about trauma-informed treatment and whether perhaps taking this approach overlooks the fact that underlying a lot of problems with addiction and substance use, that there might be trauma. And I guess you've answered in the sense that it's not necessarily an approach that's going to be taken independently of other approaches, but I wonder if there's anything more you'd like to say about that.
Yeah, I mean, obviously this has all come, particularly attentional bias training, has all come from anxiety and training people to pay less attention. And I guess there is that option, perhaps down the road, of personalising it, so the traumatic stimuli could be in there as well. But that's really a very different population to who we would intend this to be used with. And this, SWIPE is different. That is intended for people who are not seeking treatment, but certainly people who are in treatment are not excluded. But ABM, when it's in the clinic, it's really an adjunctive add-on approach. So there would be clinicians and other evidence-based psychological treatment programs to really address, to deliver trauma-informed care in that sense. Yeah.
So thank you so much, Vic. I think we've answered most of the questions, but if you have any further questions, Vic has provided her email address, and so you can certainly contact her directly. That was fantastic. I can't believe an hour has passed already, and now people can go out and enjoy the sunshine and perhaps think a little bit about everything that Vic spoke about. Virtual claps to Vic. Thank you so much for that really informative presentation today, and hope everybody stays well and keeps in touch with us here at Turning Point.
The next one?
And the next, well, you might like to say
so
something
the next one, the next Talking Point will be held on November the 18th, I believe. That's another Wednesday. And it will be Dr. Jesse Young from Melbourne University. And he'll be talking about continuing care in post-prison release and looking at mental health and AOD issues. And yeah, we're really excited. He was actually meant to be in here or at Turning Point presenting in April, but of course, things didn't quite pan out, but really, really happy that he's happy to give this sort of online webinar, live streaming version of Talking Point a go. So look forward to seeing many of you at that one. Thanks again.